So how about if we learned, how do we grow? Okay, like how do we get, remember interstitial growth is going to be the lengthening. Okay, like a tree, it grows taller, okay? So do we. All right, but also like a tree, all right, as I was going to say the shaft of the tree, the trunk of the tree gets thicker, all right, so do our bones. So that's called appositional growth. All right, but we're going to talk about interstitial growth, and that has to do with the epiphyseal growth plate. All right, and what's in the epiphyseal growth plate? Hyaline cartilage. Okay, so that's going to be the cartilage that we're going to discuss. So there's 5 zones. Okay, so we're going to start at the epiphysis. All right, and that's going to be this part of the bone here, the knobby end. All right, because remember, our epiphyseal growth plate is going to be located in this region here, the metaphysis. All right, so we're going to start at the farthest end here in the epiphysis, or close to the epiphysis, I should say. Okay, so this is easy. Look at the names of these zones too. That's going to help you out. And normally I like to pace back and forth, but I was actually listening to one of my recordings. When I get far away from the microphone, I can't really hear myself, so I'm going to have to actually, I'm going to force myself to sit. I hate sitting. But that's just what I've got to do, I guess. So look at the name of this first zone here. It's the zone, okay, of resting cartilage. So in this situation, one, we're going to be dealing with chondrocytes. That's the mature cell type for cartilage, okay? And so in this case, we're going to be dealing with mature hyaline cartilage. All right, so this is the resting zone, and that's going to be closest to the epiphysis here. All right, so now we'll move in. Let me do this too. I'll show you the pictures too as I move along. Okay, so here's zone 1, resting cartilage, and again, we don't see a lot here. The cells are interspersed throughout, all right, but not a lot, because now when we look down in here, we're going to see a lot of cells, but we'll get there. All right, so that's the zone of resting cartilage. Zone 2, proliferating. All right, so if you look at the term proliferation, this is where we're going to see an increase in number of our cartilage cells. All right, so therefore, those types of cells undergo mitosis. So we're going to see all these chondrocytes just rapidly dividing. Okay, and when they do so, they just keep pushing themselves further and further down. So they make a big stack, all right, of these rapidly dividing cells, all right, and they just push further down. And as we get further down, we just start to flatten out the lacuna even more, okay? But again, these cell columns are going to be parallel to the shaft, or the diaphysis. All right, so looking here, you can see, you can see here all of these columns, and they're just proliferating and dividing through mitosis, and they just keep pushing down and down, and they keep flattening out the lacuna and stacking themselves on top of one another. All right, so that's going to be in the second zone. And you can see, look how big the second zone is compared to the first zone. All right, not too much is going on there. Now, what happens when we get this brand new cell? All right, well, it wants to grow up just like anything else. Whoops. Am I skipping? There we go. Zone 3. All right, hypertrophy. And if you recall, the term hypertrophy means to increase in size. All right, so this is where these cells are no longer dividing, but now they're just going to start to get bigger. All right, so now, all right, we're going to see, here's an interesting fact though, all right, the lacuna, all right, they start to thin out, and that's going to be important here, because remember, we want to convert this tissue, all right, this cartilage tissue into bone. That's our end game here. All right, if you remember from last class, all right, we started off with our cartilage skeleton, but then we remodeled it into our bone skeleton. Right, that ossification, right, that hardening of the cells there, of the tissue. Well, that's what we're going to see here. But first, before we harden anything up, we got to grow it. We got to get it bigger. So that's what we're going to see in zone 3, in our where we see the hypertrophic change going on. So you can see a lot of these lacuna are nice and flat. Now you can see they kind of space out. They're now more kind of rounded, right? But the walls are starting to thin out, right? Because we're going to start to harden, all right, that tissue that's down in this area here, right? So we go from this thin, flat, not, I shouldn't say thin, but this flattened lacuna, and then now they start to get a little bit more rounded, all right? But at the same time, the walls of the lacuna become thinner, right? As we move into the calcification area here. Right? Now, it's not a very big area, but now what we see is, remember what happens? Remember what I said? Calcium is going to make things hard. It's going to harden things up. Okay? And that's what happens here. And because of that calcium coming in, it's going to destroy the chondrocytes there. They're going to die. Okay? Because they can no longer get that diffusion of nutrients into them. All right? So they've essentially coated everything with calcium. The bone matrix, or the matrix there, starts to calcify. It becomes much more harder there, right? And that in itself kills off the chondrocytes. And so they die. And then what happens after our chondrocytes die? We saw in the other types of bone ossification. Well, guess what? We start to get our osteoprogenitor cells start to infiltrate the area, all right? And along with capillaries, because capillaries are going to bring in blood and the nutrients of blood, all right, we start to break down, all right, those spaces or walls in between the lacuna, and because we brought in the osteoprogenitor cells, they're going to do what they do. They're going to divide, and out of that division, we get our osteoblasts. And our osteoblasts now start to lay down that new bone matrix on top of that calcified cartilage matrix that it uses as a scaffolding. Okay, so it's able to remodel itself. Really interesting. I don't even know if they do this anymore, but and this is actually a story as to why I'm the favorite son in my family. My mother was visiting here in Greenville. This is way before I moved down here. And my brother had a boxer, a very energetic dog, and she was in the backyard with the dog, and the dog was running around, and it hit her, clipped her, took her out. She fell, sheared off the top part of her tibia. Okay, just sheared it off. Tibial, they call it a tibial plateau fracture. And she couldn't even go back up to New York for this operation. Down here, the surgeon used sea coral. Really cool, because sea coral is highly mineralized. So this doctor used sea coral and kind of built it up at the end of the bone there, really kind of neat. And then her osteoprogenitor cells, the osteoblasts, just remodeled around the sea coral and fix the bone that way. It was actually a really fascinating. Now there's better technology than that, but it was something that was relatively, what's the term I want to use? Because it was sequel inert, it wouldn't react with the immune cells so much. And it acted as a scaffolding, much like that calcified cartilage matrix does for the osteoprogenitor cells. And that's what we're going to see here. Let me come right back to this slide here. But that's what we see here in our zones 4 and 5. You can see, all right, we've started to calcify, all right, the matrix here, the chondrocytes. You don't see the chondrocytes in the lacuna anymore. They're dead. All right, and then we get into zone 5, that ossification. You can see that red there. What is that? What's the red? Capillaries, blood. Blood is moving into that area there. All right, along with all the nutrients carried in by the blood, and at the same time, those osteoprogenitor cells are remodeling that matrix there, all right, to bone matrix instead of calcified cartilage matrix. And that's essentially, all right, how it grows. It goes through that period, not that period, but that process of making that bone matrix, all right, and it continues to do that until the epiphyseal growth plates will close. And we're actually going to talk about now what is going to trigger the closure. All right, we're going to discuss, all right, what allows or what triggers this to occur here. Okay, so keep in mind when we talk about the lengthening of the bone here, all right, the big areas here are zone 2 and 3. The proliferating zone and the hypertrophic zone there, okay? But also think of this too, because I don't want you to think of it the other way. all of this pushes that resting cartilage towards the epiphysis. So what does that mean? All right, your bone grows like this, outwards. Okay, it pushes the epiphysi, all right, away from each other. Which that makes sense, right? You got a growth plate down here, up here. You got a growth plate down here. That's why they're worried that if you ever fracture your growth plate or damage it for whatever reason, you know, if you stop growing there, you could have one limb longer than the other if it's an upper extremity or lower extremity. That's why a lot of doctors, I won't say they'll freak out, but they get concerned if you fracture your wrist because they want to make sure, depending on where that fracture site is, that it's nowhere close, all right, to the metaphysis to where your growth plate is. Okay? So we'll see a lot of this occurring throughout childhood. But then again, as we get closer to the end of adolescence, all right, we will start to see a slowing of that. And then eventually, all right, and we'll talk about this here shortly, about hormone production and how that is going to affect the growth plate, all right, eventually they'll stop. And when it stops, then there's no more, you won't have chondrocytes dividing anymore. They'll go away, all right, because that whole matrix will eventually calcify. Then the osteoprogenitor cells will remodel over that area, and boom, you're stuck with one big chunk of bone, and the only remnants that you have that there was a growth plate there is the epiphyseal line. Because it all just kind of resorbed itself. And so all the players are gone now. Chondrocytes are gone because they died, because we calcified them, done. The osteoprogenitor cells and osteoblasts infiltrated the area and remodeled it and made it all bone. And then we're done. Okay? So that's interstitial growth. All right? So that's going to be how the bone lengthens. But as you know, all right, our bones get thicker, all right, like a tree. And again, this is, if you know anything about plant biology, that's what we're going to see here with appositional growth. All right, like the trunk of a tree getting thicker. All right, we're going to see, now it's a little bit different than the trunk of a tree, because with the trunk of the tree, there's only one layer that's growing. All right, when we're discussing bone, all right, you have the periosteum. We know where that is. That's on the outside of the bone. Okay, so that's going to be, I'll zoom in here a little bit. All right, that's this kind of pinkish color here. That's the periosteum. So it's growing bone on the outside. Meanwhile, all right, you got some bone growth, not bone growth, but you have the endosteum. Remember what we saw in the endosteum? We saw osteoclasts in there, along with our osteoprogenitor cells too. So here's how it's going to work. All right, let me zoom back out. Here's how it's going to work. Here's our infant. Okay, so you got the periosteum laying down bone on the outside. We start to form that medullary cavity, but remember we have the endosteum on the inside. All right, so as this starts to get thicker, all right, the endosteum is moving through and it's resorbing the inside of the bone. So as we start to add layers to the outside and the bone starts to get thicker and thicker, through, you know, our ages, all right, starting off as an infant, then we go to child, then we go to a young adult, and then to our current state here as adults. All right, you can see that the medullary cavity is going to start to get bigger and bigger because the endosteum there, all those osteoclasts that live there, are just going to start to eat away and resorb the bone on the inside as your osteoblasts, your osteoprogenitor cells, are going to be making the outer layer, all right, adding on to and growing outwards. You can see, follow the arrows here. Okay, I'll zoom in case you can't see so well. Whoops. Okay, here you can see, all right, this picture here is showing you, here's the original infant bone. All right, so here's the amount of bone that the child grew, and eventually we're going to resorb this bone here. And you can see that's what we're starting to do. We now resorb the infant bone. Now we're left with the child bone, but we have the young adult bone on the outside. So we're going to resorb this bone here. Okay, so that's how it gets thicker. Okay, so it's going to take both the periosteum, all right, that's going to be growing the bone, laying down that bone matrix, but then the endosteum, the osteoclasts on the inside, are going to be resorbing that old bone, making the medullary cavity bigger and bigger. All right, because we got to have a place for all our blood vessels, all right? Because remember, we have a ton of blood vessels in here. We have nerve fibers in there also. All right, so we know interstitial growth. Now we know appositional growth. What the heck is this? Bone remodeling, okay? This is happening all the time, okay? Bone remodeling happens obviously a lot more when we're younger because the bone's changing. The bone's getting, it's getting taller, it's getting wider, all right? I'm not just talking about long bones, all right? But bone remodeling is going to occur. We go through some bone remodeling right now. It depends on your activity level. I'll talk about that. All right, there's two factors that influence bone remodeling: hormones and then mechanical stress, which we'll get into. So bone remodeling, just like what we saw here when we were talking about appositional growth, this occurs in the periosteum and the endosteum. All right, so you can see on average about 20% of your skeleton is going to get replaced annually. That's pretty decent. All right, only about 20%. But other areas are going to be going much quicker. Like, for example, the distal part of the femur, every 4 to 6 months. A lot of that has to do with the fact of weight bearing. Okay, it undergoes a lot of mechanical stress, so it's going to be replaced more often. Areas of bone that have to undergo more of a weight bearing or mechanical stress are going to be remodeled much more frequently. The diathesis of the femur is tough. Femur is the strongest bone in your body. It's the most difficult bone to break. It is also one of the most painful bones to break. Has anyone ever broken their femur? I had a patient that was in a car accident. She snapped both her femurs. It was one of the worst pains she's ever experienced. One of the worst. Okay? But it's very thick. If you've ever seen an actual femur, if you ever got a chance to cut it in half, the cortex, that cortical bone there, that hard outer, okay, is so thick. All right? It's very difficult to snap that in a healthy individual. All right? So when we're talking about bone remodeling, it involves obviously the bone building cells. All right? Obviously the osteocytes, because they're going to be the cells that are going to maintain that bone matrix, and they'll trigger if we need to build more bone. And then obviously osteoclasts, because what we make, we have to resorb in certain areas. Okay? So those three cells are going to play a large role in the bone remodeling process here. Okay, so let's talk about the things that influence bone remodeling. I'm going to start off with the easier one first, okay, the mechanical stress. All right, so when we deal with mechanical stress, think two things: weight-bearing movement and exercise, okay? And this is why our astronauts in space have to work out. They're in 0G, okay? And they've done a study. I don't know if anyone heard about the twins. NASA sent up, they had these, it's really cool, identical twins. They kept one on planet Earth for a year, and they shot one into space. And he lived up there for a year. Drew blood on him, all this stuff, checked his DNA. It's fascinating. There's so many things that I want to tell you, but then I wouldn't be able to teach this in the class. All right? But one of the things that they found out, well, they knew this before, okay? But one of the things that they have found out, all right, in living in low gravity or zero gravity is that your bone, through the remodeling process, will not deposit as much bone matrix unless there's weight bearing going on. That's why if you ever look, there's videos out there of astronauts running on a treadmill in space with these big straps that hold their shoulders onto the treadmill. So that creates that pressure, that weight onto the bone. So it forces that mechanical stress to be sensed by the cells in the bone. So the osteocytes will detect that stress, and then it says, hey, osteoblasts, time to make some more bone matrix. So what do? They synthesize and secrete the osteoid, the organic component of our bone matrix. Okay? What follows that? Calcification. Okay? The calcification, remember, because once we have the osteoid laid down, now we just got to sprinkle in that hydroxyapatite along the collagen fibers in the osteoid. That's no problem, okay? So we start to increase our bone mass. We see this too if we gain weight, all right? If we gain weight, all right, and if it's a gradual weight gain consistently, all right, you'll get an increased bone mass, all right? Same thing if you were to decrease weight, all right, then you would have a decreased bone mass. So basically, if we increase our weight-bearing activities, we are going to have increased bone mass. If we decrease the mechanical stress or weight-bearing activities, then we'll have decreased bone mass, 0G, okay? Sedentary, not being active, okay? I have another story, but I'll save it. Oh, I got stories. That'll be for the end. All right, so hormones. We get to talk a little bit more in detail in chapter 17 on hormones, so I'll just kind of keep it to the basics that are just involved with the bones here, okay? But hormones are chemical messengers. Here we describe them as these are molecules released from one cell into the blood. Then it travels to what we call the target cell, and then it stimulates the target cell to do whatever function it's supposed to do. But that's what happens. All right, it'll travel throughout the body by the bloodstream, all right? Then it'll bind onto what we call cellular receptors, all right? And then it will trigger these cells, all right, to enact specific changes, okay? Some of those changes will affect the rate of chondrocyte, osteoblast, and osteoclast activity, okay? So if we affect those, then we are going to affect, all right, the bone composition, the bone matrix makeup, all right, and also growth patterns. Because if we're affecting the rates of chondrocyte activity, well, where are our chondrocytes and our growth plates? So we can affect the rate of growth plate activity, meaning we can maybe, if we increase the rate of chondrocyte activity in the growth plate, then we give somebody a growth spurt. Growth hormone likes to do that, okay? So we're going to talk about that. All right, so keep in mind when we're dealing with hormones, this is a very, very basic and rudimentary definition of hormone activity, right? So you have a gland, let's say, makes and produces these chemical messengers or molecules, releases that into the blood, all right? It circulates through the blood, travels to the effector cells, all right? It binds on, or not the effector cells, the target cells, binds onto those target cells through cellular receptors, which will then enact some changes, all right? Maybe some secondary messenger, maybe some direct changes there, all right, onto these target cells. And then these target cells will undergo certain changes. Maybe they'll make proteins for something, right? Maybe they'll, again, stimulate the rate of chondrocyte, osteoblast, and osteoclast activity. All right, so let's start off with the first hormone, growth hormone. You need to know the name of this, not just for this class, but also for 211. So why wait to do it then when you can do it now, okay? Somatotropin, another name for growth hormone, right? You need to know it's made in the anterior pituitary. Then it gets released into the blood, okay? And it'll circulate throughout the blood, but as it's circulating throughout the blood, it'll go to the liver, and it'll produce what's called somatomedin. All right, we have another name for that, insulin-like growth factor 1 and 2. Don't worry about that. You'll get all that in chapter 17. All right, so growth hormone, all right, and this somatomedin are going to go to the epiphyseal growth plate and stimulate the chondrocytes, all right, to do what they do, which is what? Divide, remember? In the proliferating zone, zone 2, right? And then also to help it to undergo hypertrophy, make big and strong, okay? So that's what growth hormone's effect will be on the epiphyseal growth plate. It'll stimulate growth. So what does that mean overall? Makes your long bones longer. Gets you to grow taller. Okay? There's a lot of other things that growth hormone will do, but we're just only going to stick with bones right now. You get to worry about all that other stuff later on. All right? So our next hormone is thyroid hormone. Now again, thyroid hormone does a lot, All right, first of all, it is made in the thyroid gland. All right, but it's going to, do you know what basal metabolic rate means? All right, that's just normal operating conditions. All right, when you're sleeping at night, a lot of your tissues are undergoing their basal metabolic processes. Just enough stuff to keep you alive and just to do whatever needs to be done. Okay, so it's going to influence this basal metabolic rate. All right, and guess what? It can increase that normal activity at the epiphyseal plate. So what's that mean? It can help you grow also. Okay, help make you taller. So people that have thyroid gland issues at a young age, okay, they've damaged the thyroid gland. God forbid we're exposed to too much radiation that damaged the thyroid gland. I've actually had more than one patient that's had that. It can affect your thyroid levels, that thyroxine now. And it can, I won't say stunt your growth, but it slows your growth. You won't be able to meet your maximal potential. Okay, good so far? Growth hormone, thyroid hormone. All right, let's get to the sex hormones then. Big time, estrogen and testosterone. Okay, obviously, these hormones get produced in decent amount, very little when you're young, an infant. All right, child, when you hit puberty, bam, it jumps. And this, at this point, it's going to increase that bone growth in a large way. All right, what happens? Cartilage growth and bone formation. So now we're double dipping here with estrogen, all right, and testosterone. They're going to increase not only the amount of cartilage formation that's occurring, all right, which is that cell division, that mitosis, and that hypertrophy, but also it's going to increase that ossification process, all right, so the osteoblasts, okay, so we're double dipping here, all right, so now we're going to get more bone formation and we get more cartilage growth, okay. So it seems like these hormones that we're dealing with love the epiphyseal growth plate, all right, big time. So that's what we're going to see a lot of these hormones here, estrogen and testosterone. Questions about any of that so far? Okay. Okay. So, what do you folks know about steroids? Steroids. All right. Well, one, I know it's not good, all right, to be on long or chronic levels, what's the word I want to use? When you, prescriptions, oh, I heard a beep. Hair loss, no, tell me about it. Yeah, well, glucocorticoids are a group of steroid hormones that are produced in the adrenal cortex. And the adrenal cortex is the outer layer of your adrenal gland. You got the adrenal medulla, which is on the inside, and that produces your adrenaline hormones like epinephrine and norepinephrine. And then you've got the cortex, which surrounds the adrenal medulla, right? And that's where you have your mineral corticoids, like aldosterone, right, which helps to increase fluid levels. You also have the glucocorticoids like cortisol, right? And I'm missing one. It'll come to me. But anyways, so these guys here are going to play a huge role in blood glucose levels, especially cortisol, okay? But what will happen is, right, when we are secreting, say you have a tumor that's affecting, all right, the cortex here of the adrenal gland, all right, and you start to secrete high levels of this, it will increase bone loss, okay? Part of that is because of what occurs, again, epiphyseal growth plate. You seeing a trend here? We're seeing a lot of these hormones affecting that, all right? That's why if you have a patient or you're dealing with your own child, right, that has really bad asthma, and we're seeing this a lot more in urban areas, large amount of asthma-related cases in urban areas, and these glucocorticoids are great for asthma because they decrease inflammation. A lot of times with asthma, you have inflammation of the bronchioles, all right, causing the smooth muscles. You get that bronchoconstriction where the bronchial, the airway passages shrink down, makes it much more difficult. You give them a blast of these glucocorticoids, decreases that inflammation, relaxes the bronchioles so they can breathe easier. Problem is, if they're chronically receiving high doses for long periods of time, you're going to see bone loss. And I've seen x-rays on children who, at first glance, I thought I was looking at an 80-year-old person, a woman with osteoporosis, because the cortex of the bone was so thin. They were having issues. So glucocorticoids are not good to be given in long-term dosages for kids, especially bad asthma. Serotonin, neurotransmitter, okay? This guy right here, right? We see it a lot, we'll talk about it in this class a lot as a neurotransmitter, not so much as a hormone, but it does play a role as both, all right? But it is a chemical messenger, all right? But we found out that a lot of our bones will have specialized receptors for serotonin, all right? And again, what will happen is, all right, if we are giving people drugs, for example, SSRI. Has anyone ever heard of an SSRI, selective serotonin reuptake inhibitors? What are they used for? Antidepressant. Yeah, that's a big one. Yeah. Yeah. So you're getting these SSRIs, all right? Yep, anxiety, depression, all right? And so you're going to increase these levels. And in fact, we get them so high, look what happens. Our osteoprogenitor cells then will not turn into osteoblasts. And we can't build bone. And that's the problem, okay? We can't build bone, we can't build bone matrix. And that, again, will become a problem. So you want to avoid this, especially in children, but anybody, you know, especially if they're going, you know, like an adolescent, early 20-year-old teenager, all right? Again, this will mess up that rate and regulation of that remodeling. Because if we can't get the osteoprogenitor cells to differentiate into those osteoblasts, we can't build that bone matrix. All right, and guess what will take over? Osteoclasts. Remember, when we're dealing with bone remodeling, all right, we're building bone, but we're also tearing down bone, okay? So if the osteoblasts are inhibited and they can't make the bone matrix, and the osteoclasts continue on without being inhibited by anything, then we're going to see these patients have low bone density because the osteoclasts are resorbing everything. And we're not getting that bone being built by the osteoblast because guess what? That serotonin, all right, that we were giving that person, that those SSRIs, right, for example, are preventing the osteoprogenitor cells to differentiate into the osteoblasts. Remember, blasts build. They make the bone, okay? Ooh, blood calcium levels. I love it. All right, calcium is important. Does anyone know why? Why is calcium important? It says here, it's essential. But why is it essential? It's up there. The answers are up there on the bone. Yeah, well, it builds bone, yep. All right, we need it for muscle contraction. Okay, we'll need it for muscle contraction. We'll also need it for nerve signaling, all right, action potentials. Right? And it also is important for clotting. Okay? Well, you get to talk about its function for the pacemaker cells. Those are the nodal cells in your heart. But yeah, I mean, again, that goes back to calcium. All right? It helps to stimulate the nodal cells. Okay? So there's two hormones. This is important. If anything here, you folks should definitely know, all right, what calcium is needed for. Because we're going to talk about, well, we're going to talk about muscle contraction. We're going to talk about its function with neurons. Blood clotting is in 211. And we're talking about it right now in bones, what we need calcium for to make that hydroxyapatite. Those bone salts, the bone crystals. Okay? So we have two hormones, all right, that are going to play a role in regulating our blood calcium levels. Okay? Because when you get your blood drawn and you look there and you look at your blood calcium levels, that just tells you how much calcium you have circulating in your blood. It doesn't tell you how much calcium you have in your bone. It's a good indicator. Because usually you have to assume that if you have a decent amount in your blood, that the bones and all the other organs are satisfied, right? That they have what they need. Okay? So we have calcitriol. Ooh, what is that? There's another name for that. Does anyone know? Vitamin D. Yeah, vitamin D. Or if you're from Canada, vitamin, or England. All right. So vitamin D, and then our PTH or parathyroid hormone. All right. So let's talk about how those play a role, right, in regulating our blood calcium level, because we got to keep it. This is a lot here. And we already talked about this a little bit when we talked about the skin, the synthesis of vitamin D. And this is where I'm going to give you my PSA, public service announcement. On average, okay, I hate to say it, I used to believe that you did not, if you ate a perfect diet and you were an active person and you were outside doing stuff, that you didn't need to supplement. That's not true anymore, okay? It's not true. But that's another story for a different time. I personally take 5,000 international units IUs a day of vitamin D. Because one, I'm not outside as often as I'd like to be. And especially when the weather's like this, you can see how much of my skin is exposed to the sun. Just my face and my forehead. That's not a lot, okay? But on average, you are encouraged to have at least 50% of your skin, so like maybe a short sleeve shirt, shorts, all right, exposed to the sun for about 45 minutes each day to synthesize an adequate amount of vitamin D. If you can't get that, then you should supplement. That's my PSA for you. All right, so here's what happens when you're exposed to the sun, okay? When you're exposed to the sun, all right, your keratinocytes are going to produce, all right, cholecalciferol, all right? The ultraviolet radiation is going to strike this molecule here, and it's going to produce vitamin D3, that cholecalciferol. So it's going to float through the blood, okay? And so, all right, as it's floating through the blood, it's going to encounter the liver, all right? And in the liver, you have these specialized enzymes that will convert that molecule to calcidiol, okay? Then that's going to start floating through the blood. Then it's going to go all over the place. And eventually, it's going to get to the kidneys. And the kidneys will then convert that calcidiol into ultimately what we want, calcitriol. Okay? Calcitriol. So, calcitriol, its role is going to be to absorb calcium from the small intestine. That's what its job is. But guess what? With the help of parathyroid hormone, okay, when your parathyroid gland produces parathyroid hormone, it increases the rate of calcitriol formation. And if we have more calcitriol, then we can absorb more calcium from the small intestines. So what we say is parathyroid hormone, all right, acts synergistically with calcitriol to increase your blood calcium levels. How so? All right, parathyroid hormone increases the amount of calcitriol formed, and more calcitriol will then be able to absorb more calcium from your small intestines into the blood. And so when that occurs, we increase our blood calcium levels. Ca2+. Okay? All right, good so far? That's vitamin D. All right, now we're going to talk about parathyroid hormone. But keep in mind, parathyroid hormone increases the rate of calcitriol formation. All right, so Here you can see that picture of everything that I just described to y'all. Sun shines on your skin, okay? And you have our precursor molecule here. I love this picture because it shows the glass of milk there. And they're trying to say that you can get enough vitamin D from your milk and from the sun. Not saying that you can't, because milk is fortified with vitamin D. All right, but it's just better. You get much better, and the sun's free. Free, it doesn't cost you a dime. Okay? So the keratinocytes are going to actually produce that cholecalciferol. It circulates through the blood, reaches the liver here. Liver enzymes are going to convert that cholecalciferol into calcidiol. Okay? And then that will circulate through the blood, gets to the kidney, then the kidney enzymes convert it into calcitriol. Calcitriol increases absorption of calcium from your small intestine. But if PTH were here, parathyroid hormone, that would increase the formation of calcitriol. So we can make more of it. So we can absorb more calcium from the blood. Okay? So we can say that decreased blood calcium levels will increase the formation of calcitriol. Okay? So we have low blood calcium levels. Okay? The parathyroid gland responds to that, all right? And it releases parathyroid hormone. Okay? So the stimulus of parathyroid hormone release is reduced blood calcium levels. I've seen that asked before many times, okay? So that's the stimulus. Low blood calcium levels causes the parathyroid glands to release parathyroid hormone, and then parathyroid hormone is going to increase the formation of calcitriol by the kidney there. All right, so they're like Batman and Robin, the dynamic duo. All right, so let's find out how they affect some of our organs here. Well, on bone, check it out. We're going to increase the release of calcium from the bone. How do I do that? How do I do that? I know the answer's up there on the board, but you don't even have to see the answer on the board. How do I get calcium out of the bone? Activate the osteoclasts. Activate the cells that resorb the bone matrix, that will free up blood, calcium so it can get into the blood. So we're going to increase osteoclast activity. Okay, all right, that's one way. All right, so now we're starting to release calcium into the blood. All right, so what else can we do? Well, you got the kidney. What's its job? It's a filter. Its job is to filter out your blood. And if you're low on something, then it's not going to send it out into the urine. All right, it's going to keep it. If you're high on something, all right, if you have too much of something in your blood, then it'll excrete it. So if we're low on calcium, well, guess what? We're going to excrete less calcium in the urine. Okay? We're not going to want to get rid of it. So we're going to keep it. Okay? So that means we're going to increase that process of reabsorption. We're going to reabsorb calcium back into the blood. So you will not have calcium, or you'll have very little calcium in your pee. Good. That's good. So that's another way. Well, guess what? Now we're going to go to the small intestine. Well, guess what? Only calcitriol can work in the small intestine. Okay? PTH does not. But PTH affects calcitriol because it will help to increase its formation. It will stimulate the kidneys to convert more of that calcidiol into calcitriol. And calcitriol will then increase the absorption of calcium from the small intestine. So you see all these different ways that we're able to increase our blood calcium levels when it got low. Does it kind of make sense? I'm trying to keep it as simple as possible. I know there's a certain level of memorization here, all right? But if you think about it and you kind of think the process through, blood calcium levels are low, we want to increase that. What's that? Negative feedback, right? Okay? So how do we do that? Well, where's calcium stored? In the bone. How do we get it out of the bone? Let's activate some osteoclasts. They'll free calcium up. Now that's getting into the blood. Well, let's activate the kidneys, all right, and tell them, hey, don't get rid of calcium anymore. Don't pee it out. I know you've been peeing it out. Stop doing that. Knock that off. Let's reabsorb it more. Okay, okay. And then where else can we get calcium from? Oh, the digestive tract. All right. I just ate a whole bunch of broccoli. All right, and I drank a cup of milk with it. All right, now it's passing through my small intestine. So as I'm digesting all that material, I want to absorb as much of it as possible. And we're going to increase that absorption through vitamin D. Okay, I shouldn't say that. Calcitriol. All right, good, good so far, not bad. Hormones. So that's what we're seeing here. All right, so this goes back to, all right, chapter 1. All right, that control, that homeostasis systems. All right, I just talked about that with one of my other sections today that did the flex start. Here's our stimulus, low blood calcium levels. All right, we go to the parathyroid gland, all right, which sits on the back side of the thyroid gland, and you have these receptors there, and they detect that there's low blood calcium levels. Okay, so what does it do? It does what the parathyroid gland does. It releases parathyroid gland hormone into the blood, okay? And it starts to circulate throughout the blood. Well, what else circulates throughout the blood? Calcidiol, calcitriol, vitamin D. So it will then interact with those, okay? It'll go to the kidney, all right? The PTH goes to the kidney, and it's going to speed up the conversion of calcidiol into calcitriol. Well, that's cool, because now calcitriol can go on its way to the small intestine, and it can absorb more calcium. Okay, that's fine. So meanwhile, calcitriol and PTH go to the bones, all right, and they work on the osteoclasts to release more calcium. And also, all right, they go to the kidneys, which is fine, because they're both familiar with the kidneys anyways. They were just there converting more calcidiol into calcitriol. So now they're going to tell the kidneys, all right, listen, stop peeing out the calcium. Let's keep it, okay? And all that will then swing our homeostatic meter here from too low of blood calcium back into that normal range of homeostasis. Negative feedback. Remember, negative feedback? All right, the desired response is always going to be in the opposite direction of the stimulus. The stimulus had it too low, so we want to swing it here towards this direction, okay? And that's what happens. Gets us back into homeostasis. Okay? You're going to see that a lot, a lot, a lot. All right, Rickets, which makes me laugh every time I say this, because I had a classmate of mine at the Citadel. We used to call him Rickets because he was very bow-legged. It's not nice, but that's how we were. We were horrible to each other. But here's what happens. All right, when we're dealing with rickets, okay, we're dealing with deficient calcification of the osteoid. What does that mean? All right, well, we know what happens. Calcification is when that osteoid hardens, okay? So what does vitamin D have anything to do with that? Well, we know what vitamin D does. It helps to increase blood calcium levels. So if you're deficient in vitamin D, then we can assume that your blood calcium levels are low. So you're not going to have a lot of blood calcium. You're not going to have a lot of calcium at all. All right? So the amount of calcium you have, it won't be very high. So the osteoid that you make will not be very hard. Okay? It'll be more rubbery. Okay? Not literally, but you know what I mean. All right? It's the calcification process that makes our bone matrix hard. Makes it hard like these surfaces here that we stand on and that we're sitting on. Okay? But without that, now our osteoid tissue is going to be more soft than hard. And so weight-bearing structures are going to be affected. Well, bow-leggedness. Okay? Those weight-bearing bones, the tibia and the femur, are going to have a bow-legged appearance here. So we'll have some issues with growth. All right, if we were to take a sample of their blood, they'd be hypocalcemic. They'd have low blood calcium. All right? Dealing with tetany, okay, because if we have low blood calcium levels, and we'll learn about this when we get into muscles, tetany is having to do with muscle contractions. And I said that we need calcium, all right, to elicit muscle contractions or muscle functioning. So we'll have cramping and twitches there, okay? So we really don't see this in the U.S. unless somebody is deficient, all right, in vitamin D. Well, that could be, believe it or not, it's on the rise right now. You know why? Does anyone know why? Technology. For those of you that have kids, I know my kids don't want to go outside as much as I did when I was growing up. They want to play video games. They want to watch TV. They want to see YouTube. You know, it's weird. When I was growing up, it was a punishment to me that my parents made me come inside. Now with my kids, if I want to punish them, I make them go outside. It's weird. It's crazy. No, don't make us go outside. Get your asses outside. You're not going to be hanging out here. I don't want you around me. All right? It's just weird how that's happened. But anyways, all right. That's Rickets. Okay, so we learned about what happens when our blood calcium levels are low. Well, we've got hormones in our bodies when our blood calcium levels are too high. And I love the name of this hormone because I think of it as calcium going into stuff, calcitonin. Okay? So when again, dealing with blood calcium levels, all right, when we have high blood calcium levels, all right, we have our cells in the thyroid gland, okay, that will produce calcitonin. And you'll see it in small amounts for folks that regularly exercise, especially if they're weight bearing, like if they're a runner, because they're pounding away, you know, they'll have elevated, not significantly, but just enough, okay? Because, right, when they're dealing with, well, one, because of their diet, but actually when they're running, all right, they'll actually be causing that mechanical stress to occur. So they're increasing that bone remodeling. So at any time, osteoclast activity could be releasing calcium and releasing that calcium into, all right, into the bloodstream. Well, guess what? Now we've increased our blood calcium levels slightly, okay, because I've been exercising, all right? So what happens is calcitonin says, oh, no, we're going to shut you down. Boom, we're shutting the osteoclast down. Because that's what they do. Osteoclasts resorb the bone matrix and release calcium. So we got to cut that out. So bang. So now let's go through, right? We shut down the osteoclast activity, right? But now what else do we have to look at? Our kidneys, okay? So we're like, all right, our blood calcium levels are high. Go to the kidney, said, listen, I know I told you here last week that you need to resorb calcium and not put it into the urine. No, forget that. Now we're going to excrete it. Put the calcium into the urine so you can pee it out. Don't resorb it anymore, all right? So now we get an increased loss of calcium into the urine, okay? And we'll then bring back our blood calcium levels back to that homeostasis, okay? So that's calcitonin. Think of it as, all right, putting calcium back into stuff. So you'll see this again. You'll visit calcitonin again in chapter 17, right, when you go over the endocrine system, okay? But understand that this hormone comes from the thyroid gland. Okay, the thyroid gland is not just responsible for producing thyroxine, it's also going to produce our calcitonin, okay? And calcitonin is when our blood calcium levels are too high. That's called hypercalcemia, all right? Ooh, so now we know we're getting close to the end of the chapter. Why? Because at the end of these chapters, I always talk about age-related effects on these systems. Okay? So keep thinking, all right, we talked about it with tissues, we talked about it with skin. As we get older, we slow down. And all the processes of our body start to slow down. Okay? So let's talk about how aging affects our bone. And there's two ways that it does. One, if you remember the tensile strength of bone, all right, that is going to have to do with how flexible the bone is, how much it can resist bending, for example. All right, so guess what? The osteoblasts, just like everything else, slow down. What do? They make the osteoid. That's the organic material of our bone matrix. All right, mainly the ground substance and the protein fibers, collagen. So they start to reduce, all right, the rate of protein synthesis for that collagen, All right. Well, that's cool because, well, no, excuse me, that's not cool because now that throws the organic and inorganic ratio off. Okay. So if we reduce the organic, all right, component of our bone, but we don't change the inorganic component, by definition, if the inorganic component stays the same, but yet we reduce the organic component, by default, the amount of inorganic material increases because we have less organic. That ratio gets skewed. Point being is that bone becomes more brittle, and therefore, if it's more brittle, then it becomes more susceptible to pathological fractures. Stress fractures, for example. All right? Or it doesn't necessarily have to be a stress fracture. Hip fractures, we see in the older population. Okay? So it has to do with once the osteoblasts decrease their formation of the organic component to the matrix, all right, we have too much inorganic, and then that makes our bones brittle. All right? We also will see a loss or a decrease of calcium, magnesium, phosphate, all the other minerals there. And because we start to have a decrease in calcium and other minerals, then our bones become thinner, weaker. Osteopenia, not osteoporosis now. Osteopenia. Some people have nicknamed it pre-osteoporosis. Not really pre-osteoporosis. Osteopenia, by definition, is just a decrease in bone density. Okay? Decreased bone density. And then there's certain levels. If it's really bad, then we call it osteoporosis. All right? But osteopenia is where we're going to see a decrease in bone density, and it makes the bone thinner and weaker, more susceptible to certain pathologies. I'm not going to necessarily say a fracture, but it can eventually lead up to that. All right. So osteopenia, believe it or not, will start at age 35 to 40. But, if you are somewhat active, and when I say active, if you're walking, the simple fact of walking. I had a roommate, and I hate to say this, I know he was over the age of 40, and I used to take my dog for a walk almost every night, and he came and lived with me for a year. And so I remember that I invited him to go on a walk with me. And I don't walk fast, and I don't walk far, right? But within the first half a mile, he says, I can't do this. I said, that's a scary thought. You're a 40-plus-year-old man, and if you can't just do the simple act of walking, then you need to start addressing some of your health concerns. And I'm very blunt when it comes to that stuff. You know, he's my friend, so I feel like there's a certain thing. Now, if one of you were to come and say something to me, I'd probably be a little bit nicer, all right? But I feel like I needed to be blunt with him because of time. But as we get older, right, you will increase the possibility of osteopenia. But we saw that mechanical stress, okay, by walking, weight-bearing exercises can offset osteopenia. All right, as long as you have the right nutrient levels, that you're providing your body with the right ingredients, obviously enough calcium, enough phosphate, all right, and your activity levels are going to be at a decent level, then that will stimulate the osteoblasts. Okay, but if that's not happening, okay, and you're a relatively sedentary person, say you got a job at a desk and you have to work 60, 80 hours a week. Well, what will happen then? Okay, well, osteoblasts will start to decline, and so if our osteoblasts decline, they're not making osteoid, but guess what? Osteoclasts don't slow down. They keep going. They're happy to keep doing what they're doing. Well, gosh darn it, that's a bad relationship. Right? Because the osteoblasts aren't building enough bone to keep up the rate that the osteoclasts are tearing down the bone. So now we're resorbing more bone than we're building. So we'll start to see a decrease in bone mass. Look at these vertebrae. We already know what they do, weight bearing, right? You see that in the axial skeleton. Okay? The epiphyses of some of our large bones, weight bearing bones. You see it in the femur. Okay, and the tibia, all over the place. Unfortunately, and I apologize, ladies, that we see it a little bit more than you, in you than we do us men. Again, and part of that is going to be because of the sex hormones, estrogen, progesterone versus testosterone. It's just how it is. Sorry. Okay, osteoporosis, the big one here. All right, now this is when your bone density has gotten so bad, all right, that it now starts to compromise the normal function. We know what the function of bones are, mainly support. Okay, so if we can't support, what's going to happen then? We can start to see an increased incidence of fractures, okay, bone pain, degeneration, all right, even, God forbid, osteoarthritis, okay? So we will see it in both older men and women, but in a much more significant number in women, okay? And you can see right here, estrogen, testosterone, those they start to take a deep nosedive, all right, in our latter years, even growth hormone, all right? But see, some of those, I mean, especially like with growth hormone, if you challenge your body, like if you're exercising and working out, all right, that will stimulate, all right, the release of more growth hormone. So if activity levels increase, like if you're freak of nature and you're like, what's his name? He died a couple of years ago. Jack LaLanne. Does anyone remember Jack LaLanne? He's the guy that wore the jumpsuit all the time. He was nuts. I think he died in his 90s. Pneumonia, I believe. Well, anyways, when he was like 67, he swam across the San Francisco Bay with like 67 rowboats chained to him. He was unbelievable. Hardcore. Well, anyways, I mean, he proved that you could still produce a decent amount of growth hormone, right? But the whole issue is when we're dealing with osteoporosis, we're going to see a significant reduction in the amount of bone mass that is present, okay, because of, all right, a reduction in the hormones. Mechanical stress will play a role, but if you're, again, sedentary, you're not going to be placing mechanical stress on the skeleton and it won't respond, right? But a lot of this is going to be hormone reduction, okay? Osteoporosis. Darn you, osteoporosis. Okay. So here's just a little bit more in detail about osteoporosis. And again, the older, and especially for ladies, and this is kind of where they really drew a strong correlation between the relation of hormones and its effects on osteoporosis, because when women went through menopause, their osteoporosis rates when they were done with menopause just shot up, all right, because they pretty much aren't producing, all right, their sexual hormones anymore, their sex hormones anymore, all right, and so we saw a big increase in osteoporosis with menopause. Obviously, smoking, I mean, to be honest with you, what doesn't smoking really I mean, not to be like that, but we definitely do see that smoking will play a role in that. But a lot of times, people don't really get diagnosed with osteoporosis until they've had some sort of fracture, okay? Broken hip, see it all the time. Now the question is, you know, you'll hear the story of grandma or somebody's older relative falling, and they broke their hip. Well, here's the question, and they have osteoporosis. Did they fall and break their hip? So did the fall cause the hip to break, or did the hip break and then they fell? Because there are reported incidences of that, okay? So it's not uncommon. So we will see quite a bit. You hear more about it in the hip, all right? But I've seen tons of evidence of osteoporosis, because that's what I look at, are MRIs and CT scans and x-rays of the spine all the time, okay? So how do we treat it? Obviously, we try to prevent it. Diet, okay? Lots of calcium, lots of magnesium, okay? And then physical activity, big time. So the more you do now, it will prevent issues later on in your life. All right, and then there's, of course, drugs, all right? I can't remember the name of it. Viroclast, I believe it is a big osteoporosis drug in which it does help with, believe it or not, new bone growth. All right, we can get the bones to grow a little bit and stimulate those osteoblasts. It'll make a huge, let's get that one, huge deal. All right, let's move on to the last part. Bone fracture and repair. So this is just a couple of types of fractures that I do want you to know, okay? What's a fracture? It's a broken bone, okay? So the stress fracture, we've all heard about stress fractures, or most of us have, right? It's in the runner, somebody that's on their feet all the time. But basically, it's associated with these small, tiny little fractures because of increased physical activity, okay? Pathological fracture, good friend of mine, one of my best friends, he's schizophrenic. And we went to Blockbuster Video. Does anyone remember Blockbuster Video? Yeah, you do. Yeah. So I always would go to Blockbuster Video and walk along the outside wall because that's where all the new releases were. So I'll never forget this night when we were in there. He's a very big guy because of all the schizophrenic medications that he's on. It slowed down his metabolism. So I think at that point he was probably close to about 400 pounds. Big fella, shorter than me. So we made it around almost the entirety of the whole thing, and we actually had the movie. And so I remember when we were getting close to the end, he goes, "See, I gotta go sit down." And I'm like, "Are you kidding me?" I don't want you to think that I'm not a very, very sympathetic person, but I'm like, "Really? We've only been in here for like 5-10 minutes." He goes, "Man, I just gotta go sit down." I said, "Okay. We've got the movie. Let's just go check out." No lie. As we went to go and turn to go check out, he just crumpled to the ground. Just went down. And I was like, "What the heck happened?" And he's like, "I broke my ankle." I was like, "There's no way you broke your ankle." And he's holding his leg there, and his ankle's like flopped in a really awkward position. No lie, he broke his tibia and his fibula, and those drugs that he was on caused the bones to undergo, they decreased their bone density. That was one. And plus, he wasn't, because of the drugs, they took away his energy level. He just didn't have he didn't get a lot of physical activity. Those two things combined cause a weakening of the bone, and that simple just turning on his ankle, all right, and then that shifting of weight caused that pathological fracture. It was the darndest thing. And the part that really bothered me, that bothered me, don't get me wrong. The part that really bothered me is that the Blockbuster Video people accused us of being drunk. I said, where did that even come from? I know, it's crazy. It took 4 of us to get them on the green though. All right, a simple fracture, when we break the bone, but it does not penetrate through the skin, the compound, that's the one that pierces the skin. And that's the one you have to really be careful of. Infection, okay, and compound fracture, you have to be worried about embolism, bad embolism, okay? Because, remember, you have that yellow bone marrow, which is a high-fat compound in the bone cavity there, in the medullary cavity. If it gets into the bloodstream, that's a problem. All right, this is on 7.6. This is a whole bunch of just different types of fractures. You can feel free to look at that. But I want to hit the last part here, and that is, all right, bone fracture and how it heals, okay? Now, when we talk about the healing process of a bone fracture, yes, it'll take 2 to 3 months for it to completely heal, but there's not really any evidence of the fracture side. All right, the further you are away from the heart, it might take a little bit longer. It'll probably be more towards the 3-month, the latter portion of that. All right, obviously, a compound fracture, if the bone broke the skin, that means there's a significant amount of misalignment going on. So usually you'll have to get an orthopedist in there to go in there and set the bone. But a simple fracture, usually there's not that much misalignment going on, easy to deal with. Okay, so the first step of a bone fracture, all right, you're going to get your blood scab, I call it, okay? So you fracture the bone. Remember, bone is highly vascularized. So when you fracture the bone, you damage blood vessels. Not only that in the bone, but also in the periosteum. We'll come back to the slide here, show you a picture. So that's what we're seeing here. All right, so here we've broken the bone here. We've got blood vessels within the bone in the medullary cavity and throughout the cortex here, and then also throughout the periosteum. Regardless, all right, when we compromise those blood vessels, they will start to fill in that area there, okay? So that's one of the things that if anyone here has ever broken a bone and they didn't put you in a cast right away, that happened to me. I broke my tibia when I was in 4th grade in a sledding accident. and they didn't put, I had to be splinted for 3 days. It was excruciating. And the fact that my father didn't believe me. He thought that I just sprained my leg. And so here I am trying to walk on a broken bone. My dad's like, listen, if you don't get up and walk on that, the longer you wait to get up and walk on it, it'll hurt even more if you don't get on and walk it. So here I'm thinking, man, this hurts a lot now. How much more can this hurt? So I'm limping on this leg. And finally, my mom's like, we're going to the hospital. And it was broken. And my dad, he felt that. In fact, I'll call him tonight and remind him. All right, so that's the first phase there, okay? So we start to see, all right, the blood infiltrate the area, okay? So now what we're going to do is, and again, we've seen this, it's very similar. We get what we call the fibrocartilaginous callus, okay? So now we're going to start to get the formation of that early, not so much bone tissue, but cartilage tissue. Okay, so we're going to get kind of what we call it the procallus phase, but it's going to be that cartilaginous tissue here, along with, guess what? There are fibroblasts, and that's great because fibroblasts produce collagen. Collagen is going to add security and strength to that area there. So what will happen is that hematoma, that big scab there, is going to reorganize itself. We'll get some fibroblasts in there. They're going to start to lay down some collagen, and then guess what? Chondroblasts get on site, and they're going to start to lay down their matrix, which is a dense, regular connective tissue. Dense, regular connective tissue has the tensile strength of ligaments and tendons. So they'll infiltrate that area. So with the fibroblasts and the chondroblasts together, they make that fibrocartilaginous callus, right, that kind of model that we're going to make our bone matrix around, okay? So I'll show you real quick here, come back to that slide. So that's what we're seeing here. Okay, so here's our hematoma. Right now, our hematoma starts to reorganize itself, and we start to get chondroblasts infiltrating this area. We start to get our fibroblasts in here, so they're laying down collagen. The chondroblasts are laying down that dense, regular connective tissue. So we're starting to make almost kind of like a cartilage kind of brace here. All right, so we're starting to kind of fix things, getting some structure in here. Definitely trying to stop the bleed. That's the big thing. All right, so between the fibroblasts and the chondroblasts, we get this procallus structure. All right, we nickname it the soft callus because it's soft because it's still kind of flexible. It's not going to be hard like bone, all right, because it's made of a different type of connective tissue. All right, so then that moves us on to this phase here. We're going to now, and we know the story, we're going to convert it into a hard callus. All right, we're going to convert it into bone. Okay, so how do we do that? Well, guess what? We get our osteoblasts on site. Okay, so they move into that area, and then we're going to start to lay down our bone matrix. All right, we're going to start to form, all right, trabeculae, all right, bone spicules there. And so we go from that soft callus now to that hard bony callus. All right, but this is woven bone. It's an immature bone. It's not very good. It's good enough because our goal is to reunite the broken ends of the bone. Okay, so over time, that cartilage callus will be remodeled over. We know how, and we already know how we do that. Calcification, then our osteoblasts move in, and we start to lay down what we call this woven bone. And that's why we say that this callus has trabeculae. So you'll see these bone spicules just kind of all over the place. It's not very well organized, but guess what? It'll do. Remember when we were talking about intramembranous ossification and how the mesenchymal islands will start to produce that first kind of early form of bone, that immature woven bone? It happens here. Same thing. Same thing. And then we're going to remodel it into the lamellar bone, the mature bone, the better bone. Okay? So I'll show you here. And you can even see on the picture. Look at this. Okay, so we have all these trabeculae all over the place. Okay, but now we've converted all right, this fibrocartilaginous, or this soft callus that was like cartilage, all right, collagen makeup, and we converted it now over into this immature early form of bone. All right, it's not very well organized, but that's no problem, because we're going to reorganize it when we resorb the bone. We're going to remodel it here. All right, but we just got to get that bone tissue in here now. And that leads us on to the last phase. All right, and that's our remodeling. And this goes on for quite some time. All right, weeks, months. Okay, so now, all right, we're going to get rid of any extra bone that might be lying around. We'll get rid of that. But now we're going to replace, all right, that primary bone, all right, with a much better form of that compact bone. All right, primary bone, also known as woven bone. Now we're going to change it over to lamellar bone, which is more kind of layered. All right, it has more organization to it. And we're just going to kind of clean up the area. All right, and the remodeling goes on for some time. In fact, when I broke my leg, I used to have a little bump on my tibia, and it went away years later because it was constantly remodeling. All right, let me show you that last picture here real fast. Right here. Okay, so again, we kind of resorbed that trabecular bone that was sitting in the inside here. We, so we've reestablished our medullary cavity. And yeah, you'll have some extra bone here and here. And over time, that will remodel and it'll resorb. But you can kind of see how we had all this porous, all right, cancellous bone here, right? That's that primary woven bone. All right, so at this phase here, we've reestablished our compact bone, okay? And then we've reestablished our medullary cavity, and then over weeks, months, this will all eventually go away and it will all look like it once did, okay? So that's the remodeling phase. That's it. It's bone. Bone's over with. What do you guys think? Not too bad? Not impressed? It's a lot, I know. So, I know it is a lot. It's true. But keep in mind now, all right, you understand a little bit about how bone is formed. All right, there's going to be a significant, I won't say significant, but a decent amount. I would focus on, when you're studying for the test, the hormones. Know what the hormones do to the bone. Okay, there'll be a couple questions. Obviously, there'll be questions on all this material. But hormones, we see quite a bit, so understand how calcitonin, how it affects the bone directly, how it affects the kidneys, or how PTH affects the kidneys and the bone, all that. I've become very familiar with that. I've become very familiar with the roles of the cells, what cell does what osteoclasts do, what osteoblasts do, and just kind of be familiar with what occurs in the endochondral versus the intramembranous ossification processes too. All right, it won't be too terribly specific. They want to understand, we want to know how your understanding of that whole idea of start off with cartilage matrix, it gets calcified, and then we build the bony matrix over that. All right, that kind of relationship. If you know that, it shouldn't be too difficult. All right, let's take a break. I kept talking here for a little bit. We'll be back here in about 10 minutes. And we'll do some lab stuff.